Hello everyone. So here is another session. The topic is temporomandibular joint. The SLOs of the topic are, at the end of the session you should be able to describe type and articulation of temporomandibular joint, how the muscle of mastication act on the joint, the movement at the temporomandibular joint, and what are the feature of temporomandibular joint dislocation. So what is temporomandibular joint? You can see here the TM joint is synovial joint of condylar or bicondylar variety. It is present between the glenoid or mandibular fossa present here on the temporal bone and the condyle or the head of the mandible. It is a complex type of joint. As you know already what is complex type of joint. That means the joint where there are two cavities because of one articular disc. So here you can see, can you see the joint here? You can see the enlarged view. This is the whole of the joint, and here in between there is the articular disc. So the articular surface is lined by fibrocartilage. It is not lined by the hyaline cartilage which normally is present, which normally lines the synovial joint. So we can say that TM joint is a typical type of synovial joint. Also it is complex type joint because there is one fibrocartilaginous articular disc which divides the joint cavity into two. There is upper one which is known as discotemporal or meniscotemporal, okay, and the lower one which is known as discomandibular or meniscomandibular part or the cavity of the joint. Okay, so I hope you understood what is meaning of complex joint here, why we are calling the TMJ as complex joint. Disc means the fibrocartilaginous articular disc, okay, or the same word we can use as menisci here. Okay, so discotemporal or meniscotemporal is upper cavity and the lower cavity is discomandibular or meniscomandibular, and this is the whole joint. Okay, now here you can see the articular surfaces. Okay, so you can see here there is this one articular eminence, then there is the articular tubercle, then there is tympanic plate. So all these are contributing for the making one cavity. Okay, so there is articular tubercle, here there is articular eminence, there is tympanic plate, okay, and there is a squamotympanic fissure. All these are belonging to the temporal bone. Okay, fine. And here you can see the postglenoid tubercle also. So this is the here you can see the fossa, and remaining all these are the parts. So all will be here related here to the forming the fossa where the head of the mandible will be articulating, and that will be forming the temporomandibular joint. Now you can see here the head of the mandible which is articulating here and forming the temporomandibular joint. Then as we know, what is the second thing which we should know about the any joint after the articulating surface? It is the ligament related with the joint. So you can see here there is capsular ligament. Okay, this is capsular ligament. Then there is temporomandibular or lateral ligament. Then there is here, which is not visible clearly because it is on the inner aspect, this is known as sphenomandibular ligament, and this is known as stylomandibular ligament. So there are four ligaments. So capsular ligament, along with that there will be on the inner aspect there will be synovial membrane. Okay, so this is capsular ligament, this is the temporomandibular or lateral ligament, this is sphenomandibular ligament, and this is stylomandibular ligament. Okay, remember sphenomandibular and stylomandibular ligament, they are accessory ligament to the temporomandibular joint because they are not primarily related here to the temporomandibular joint. Okay, now capsular ligament, you have to see the attachment of the capsular ligament. So superiorly it is attached to the articular eminence and articular tubercle. Just now I have told you the articulating surfaces, articulating structure. So there is anteriorly, here there will be articular eminence and articular tubercle, and laterally there is peripheral, which is not visible here, got cut here, that is periphery of the mandibular fossa. Posteriorly there will be squamotympanic fissure. Squamotympanic fissure is a fissure which is present between the squamous part of the temporal bone and the tympanic plate of the temporal bone. Okay, so here is the tympanic plate. When you will read about the external auditory meatus, middle ear, then you will know what is the tympanic plate. Okay, and inferior attachment you can see here, periphery of the neck of the mandible here. So all these are providing attachment to the capsular ligament of the temporomandibular joint. Now here you can see the capsular ligament attached to the peripheral of the articular disc, and it is anteriorly blending with the, here can you see, it is attached to the periphery of the articular disc, and here can you see this muscle, this is inserting here, so it is blending with the insertion of lateral pterygoid, and the lower fibers of the capsular ligament which are tight fiber, okay, here, so they are known as collateral ligament, and upper fiber will be the loose fiber. Okay, you can see here the two part of the lateral pterygoid, you can see the superior and the inferior head of the, you can see these are the parts of the lateral pterygoid which are inserting here into the neck of the mandible. Okay, now the synovial membrane, so you can see here on the inner aspect, it lines the inner aspect of the capsule except the articular disc and articular cartilage. So it does not lines the articular disc and the articular cartilage. It provides lubrication to the joint and also nutrition to the disc. Then lateral or temporomandibular ligament. Can you see here? This is the, or you can see here, this is lateral or temporomandibular ligament. It reinforces the joint capsule laterally and articular tubercle on the route of zygomatic process to lateral surface and posterior border of neck of condyle are the attachment. You can see here, I have shown you already, the articular tubercle is present on the zygomatic process of the temporal bone. Okay, so here attached, and from here it is reaching to the lateral surface and posterior border of the neck of condyle. Okay, now the accessory ligament I have already told you. First we will see the stylomandibular ligament which you are seeing here. It is attached to the styloid process and to the angle of the mandible. Stylomandibular ligament you would have heard in the embryology of pharyngeal arches also. Okay, now here you see the sphenomandibular ligament. It comes here from the spine of the sphenoid to the lingula of the mandibular foramina. Here this is the mandibular foramina, of that there is lingula to which this ligament is attached to, that is sphenomandibular ligament. You are seeing on the inner aspect, you are able to see these two structure. There is inferior alveolar nerve and the inferior alveolar artery. They are entering into the canal, and outside one nerve is there, that is the nerve to mylohyoid. You can see here the posterior division of the mandibular nerve. You can see the branches. Okay, so that is about the accessory ligaments. to the temporomandibular joint. Now the articular disc. Can you see the articular disc here? As I have already mentioned, it is dividing the joint cavity into two compartments where different movements will be there, and also because of this articular disc, TM joint is a complex type of synovial joint. So it is avascular dense fibrous connective tissue. Edges are fused with the fibrous capsule. So here is edge, here is edge, and degenerated. It is actually degenerated primitive insertion of lateral pterygoid. Okay, so lateral pterygoid degenerated insertion is nothing but the articular disc. It is dividing the joint cavity. Here is the image of the dissection of the temporomandibular joint. Okay, now what are the relations of whatever you have seen the structure apart from or nearby the temporomandibular joint? Those are present. So you can see anteriorly there is lateral pterygoid muscle, and here there will be mesenteric vessels and nerves. Remember, mesenteric artery is branched from the second part of the maxillary. Here is the second part of the maxillary artery where all are the muscular branches. You can see here the first part where the 5 branches will be coming. Remember, inferior alveolar artery, there is deep auricular artery, there is middle meningeal artery, there is anterior tympanic artery, there is accessory meningeal artery. Second part, all the muscular branches from the maxillary artery are there, whether it is the deep temporal supplying the temporalis muscle, mesenteric branch, or the medial and lateral pterygoid branches. Okay, and here you can see the infraorbital artery. Okay, and you can see here the posterior superior alveolar artery. These are the branches from the third part of the maxillary artery. Remaining there is no need to talk about. Okay, here you can see so these are the anterior relation, lateral pterygoid and the mesenteric vessels and nerve, and the posterior relation will be here, the part of the parotid gland, superficial temporal vessel. Can you see here the termination of external carotid artery? This is the maxillary artery and this is superficial temporal artery. Then there is auriculotemporal nerve coming from the posterior division of the mandibular nerve, and there is external acoustic meatus here. This is the external acoustic meatus. So you can see the anterior relation and the posterior relation of temporomandibular joint. Now laterally, if you are able to see the joint here, what is present outside? Skin, fascia, parotid gland and the temporal branch of facial nerve, whatever you have seen during the dissection of the parotid gland. And here medially, if you see, there is all these structure. You can see the spine of sphenoid. Just now I mentioned the spine of sphenoid is giving attachment to the sphenomandibular ligament. Obviously sphenomandibular ligament is there. Can you see here the sphenomandibular ligament is cut here, it is not seen. From here to here this ligament will be there. Then obviously auriculotemporal nerve is there. Can you see here auriculotemporal nerve? So this is auriculotemporal nerve, here is inferior alveolar nerve, this is the lingual nerve. How you will identify all these three nerves? If you are dissecting, if you are able to see a nerve where another nerve is coming and joining at an acute angle, so that nerve is lingual nerve, and this nerve is called a tympani nerve. Okay, this is a nerve which is getting along with another artery, it is entering here into a canal. So this artery is inferior alveolar artery and the nerve is inferior alveolar nerve, and obviously along with that there will be nerve to mylohyoid. And here you can see the two roots of a nerve are encircling an artery. Okay, so that artery is middle meningeal artery. Okay, so that is how you will identify middle meningeal artery will be present between the two root of the auriculotemporal nerve. Can you see here auriculotemporal nerve is going? So you are able to see the posterior division of the mandibular nerve, and you can see here this is the foramen ovale and this is the foramen spinosum. Foramen ovale male structure, foramen spinosum the men structure. Okay, I have shown you already middle this is coda tympani nerve, and there is middle meningeal artery. So all these are the medial relation, okay, and these the lateral relation are present here. Now what is the nerve supply and what is the vascular supply? Obviously the auriculotemporal vessels, not actually auriculotemporal vessels, but the branches from the maxillary artery which supply, and nerve supply is auriculotemporal nerve, okay. So auriculotemporal nerve, posterior division, and mesenteric branch which is from the anterior division, which also supply the mesenteric muscle, and it gives a branch to the temporomandibular joint. Also lymphatic drainage is to upper deep cervical nodes around the IJV. Remember, jugulo-digastric lymph node. Now what are the movements and mechanism? So you can see here the movements, as you have already seen during the muscle of mastication. There is elevation, depression, there is protrusion, retraction, there is side to side movement. So there is sliding or translation movement which occurs in the discotemporal or meniscotemporal compartment, okay, and rotation or hinging movement that is occurring in the discomandibular or meniscomandibular compartment. So these two compartment has different movement, and these movement are movement of the mandible, okay. Here these are the movement which are happening within the temporomandibular joint, okay. So these are happening within the temporomandibular joint because there are two different cavities are there because of the articular disc, and these are the movement of the mandible, whether it is going upwards, going downwards, protruding forward or backward, or side to side movement. Now you can see here all the muscle of mastication. This is, you can see the temporalis, you can see the mesenteric muscle, you can see here the superior and the inferior head of the lateral pterygoid having a common insertion, okay, and you can see here the smaller one superficial and the bigger one the deep head of the medial pterygoid. So four muscle of mastication. You can see the temporalis, fan shaped muscle, you can see the mesenteric. Once you remove the mesenteric to one side, you can see the medial pterygoid, you can see the lateral pterygoid, okay. So this is the superior head and inferior head. This is of the lateral pterygoid, superficial head and deep head of the medial pterygoid. So you can say that the inferior head of the lateral pterygoid is sandwiched between the superficial and deep head of the medial pterygoid, okay. So these are the muscle of mastication. I am not going in detail of this, okay. So you can see here first there is depression. So depression is because of contraction of digastric and geniohyoid, and you already know these are the suprahyoid muscle, and this leads to the rotation of the condyles in discomandibular compartment. Remember discomandibular compartment, the lower compartment, and both lateral pterygoid contraction leads to sliding of condyle in the discotemporal compartment, okay. So that is, these both movement are responsible for depression, and it is aided by the gravity. You can see here, can you see the video here? This is depression. What muscles are acting? Lateral pterygoid is primary muscle which is doing the depression, and aided by the accessory muscle, that is digastric and geniohyoid, okay, which are, so digastric and geniohyoid, you can see here digastric and the geniohyoid. Geniohyoid is here, this muscle from inferior genial tubercle to the hyoid bone, and here this one is digastric which is here coming to the hyoid bone. So they are acting on the discomandibular compartment, and if you see here will be the lateral pterygoid which will be acting on the discotemporal compartment. This is depression, okay. Now you can see here the elevation. Elevation is contraction of posterior fiber of temporal. You can see here these are the posterior fiber of, okay. So you can see the posterior most fibers are almost horizontal, okay. So these are helping the sliding of condyle in the discotemporal or the upper compartment, and here you can see the masseter, medial pterygoid and anterior fibers of temporalis. These are responsible for rotation of condyles in the discomandibular compartment. Okay, you can see the masseter here, you can see the anterior fiber of the temporalis, and medial pterygoid fibers are not visible here. Okay, but they will be inserted on the inner or the medial surface of the ramus of the mandible. So now you can see here what movement you are seeing, that is elevation. You can see here, can you see here elevation? What is the primary muscle for elevation? You can see it is the temporalis also, because it is acting on the discotemporal compartment. Then there is medial pterygoid, masseter, anterior fibers of temporalis also, but they are acting on the discomandibular compartment. Okay, so then there is protrusion and retraction. Okay, protrusion and retraction. So here sliding of condyle in discotemporal compartment, you can see the forward sliding. Okay, now here we are talking about only one compartment, that is discotemporal compartment, the upper compartment. So forward sliding is protrusion. Why that happens? That is happening because simultaneous contraction of medial and lateral pterygoid of both sides, that is protrusion or forward movement of the mandible. And you can see the backward sliding, or also known as retraction, that is because of contraction of the posterior horizontal fibers of temporalis on both sides. Just now we saw if single side, in the previous slide we saw, here simultaneously both side temporalis fibers, they are responsible for retraction. Can you see here the protrusion and retraction? Remember, not both the compartment are involved, only the discotemporal compartment is involved. This is protraction or protrusion, both are same thing, and retraction. Okay, now the symmetric jaw opening and closing. Now here what happened? They happens in particular sequence. First there will be depression, then there will be protrusion, then there will be retraction, then there will be elevation. That means all the muscles are acting in sequence, and then you will be seeing the movement. Okay, so you can see here there is a depression, then there is protraction, protrusion, then there is retraction, and then there is elevation. So this is symmetric jaw opening and closing. Where it happens? It happens during the chewing. Okay, so you can see the movement, symmetric jaw opening and closing, but that will be in order. First there will be depression, then protrusion, then retraction, then elevation. Okay, so this is envelope of motion. Now side to side chewing movement. Now here shearing force which is needed for effective of tearing down of the food. Okay, so it is eccentric opening and closing, and condyle of active side rotate in vertical axis. Okay, so here the condyle of inactive side will move forward and backward. So this is side to side movement. You can see here. Okay, you can see here one side it is the active side condyle is moving in vertical and in vertical axis only, and inactive side is moving in the forward and backward direction. This is side to side chewing movement. There is difference between side to side chewing movement and the previous slide which I have shown you. You can see the symmetric jaw opening and closing. This is symmetric jaw opening and closing. This is side to side chewing movement. You can see here. Now range of motion. Okay, so maximum opening of jaw is about 50 millimeter. Functional range it is 40 millimeter only. Okay, 25 millimeter by rotation and 15 millimeter by anterior gliding. Maximum range of protrusion and lateral displacement are 10 millimeter each. Sometime later it might be asked in your NEET PG. Okay, but not for UG's range and all that will not be asked. Okay, stability of the joint. So temporomandibular joint is occlusal position of mandible provides the maximum stability. Okay, because it is present and it is surrounded by all the structure. Okay, so because of that there will be maximum stability. Forward displacement is prevented by articular tubercle and the tension of the temporalis. These will be preventing the forward displacement, okay, and backward displacement is prevented by the postglenoid tubercle, temporomandibular ligament and tension of lateral pterygoid. So these are responsible for the stability of the joint. Now what is this? Applied anatomy. So related to the temporomandibular joint, most common applied anatomy is, the condition related is temporomandibular joint dislocation. What can be the cause? Excessive yawning, violent blow to the jaw or convulsive spasm of lateral pterygoid. So here what happens? The condyles slip beyond the articular tubercle and lie in the infratemporal fossa. Articular tubercle and spasm of masseter makes it impossible for the condyle to move backward. Remember, the condyle is not going behind, it is coming in front. You can see here the condyle normally present here and it is not going behind, it is displaced and coming into the infratemporal fossa, that is temporomandibular joint. Why it is not going behind? Because of presence of articular tubercle and the muscle masseter which is present here, so it does not allow backward movement of the joint in the temporomandibular dislocation. What is the management of temporomandibular joint dislocation? It is the reduction of the joint. Reduction of the joint means you have to forcefully, you have to fit that back into the mandibular fossa. So that is how you are supposed to do the reduction. So you can see first it has to be downward, then you can see upwards direction, and then you have to go and fit here. So that is the reduction of the temporomandibular joint. So that is today's topic, that is temporomandibular joint. Thank you.